Okay, good afternoon. This is the first piece of our perfusion lecture. We'll start with hypertension. So the overall goals, objectives here of our perfusion section. Look at these, just applying the nursing knowledge. Don't forget, everything we discuss is always about what is the nursing emphasis, the nursing knowledge. The primary prevention, this is one of our biggest efforts in hypertension. Healthy People 2020 defines several things, and these are kind of the highlights of that. Achieving a healthy weight, sodium intake reduction, limiting or increasing physical activity, quit smoking, and diet and alcohol also. And we'll get into more of these as we talk about it, but this is a big goal of hypertension. You think about what could be secondary or tertiary prevention, and gets a little bit stickier. We're going to focus on primary prevention. Secondary, tertiary, so medication, education, etc. will all be another big part of this. All right, so let's talk risk factors briefly. I know y'all are familiar with these, but these are going to apply not just to hypertension, but to most of our cardiovascular concerns. So these are great. We have, remember, unmodifiable, the ones you can't change, and then we'll talk about modifiable risk factors too. So the ones we cannot change: age. Blood pressure goes up with age. Nothing we can do about that. Ethnicity, it is twice as high in African Americans than in whites. And then family history, especially a close blood relative that has high blood pressure, you are more likely. So if your dad has it, you're more likely. Gender has an interesting twist to it. For young adults or anyone under 55, it actually is more prevalent in men, and then it switches and becomes more prevalent in women after 55. So now we'll get into the modifiable. So these are the ones you can do something about. Can't do anything about my age, my race, or my gender. However, with lifestyle, it's huge. Obesity. Obviously a huge epidemic in the U.S. right now. Keeping your BMIs less than 25, and there's also a bigger concern here with what we call central abdominal fat, which we'll talk about more in other diseases too. So a good one to keep down. So low-fat diets, low-sodium diets, especially when we talk about hypertension, low sodium becomes a key. Quit smoking. Then what else is there that quit smoking? And also illicit drug use, and then over-the-counter for certain things, especially antihistamines or diet pills. Stress, socioeconomic status, which you can argue whether this is modifiable or unmodifiable, but it falls in our modifiable risk factor. So this is more prevalent in lower socioeconomic groups and among undereducated people. Alcohol risk factor. Women, we can have, basically all these are the same. Sorry, this is doing a screen capture on mine, so I didn't catch that popping up. All those are the same, in case you were unaware. One beer, one actual serving size glass of wine, or 1 ounce or shot of liquor, all have the same amount of alcohol in them. Men can handle basically 2. So women, 1 drink a day, men, 2 drinks a day. Anything more than that starts to add some risk factors. And then, of course, sedentary lifestyle. You need at least 30 minutes of aerobic activity most days. So that's interesting. People that say, oh, I exercise every day, or I'm not sedentary. My job, I walk around a lot. That doesn't really qualify. You need 30 minutes of aerobic activity most days. Okay. Hypertension, we'll talk about now specifically. I'm going to go through this a little briefly because this works better in person, but I'm giving you an example of some primary prevention methods. Student working at a health fair, service learning at a local mall. Sally was shopping, stopped at the booth. All right, she's 42-year-old white female, married, 2 teenage sons. She smokes a pack a day. She says she walks her dog 2 days a week. But that still puts her in lifestyle as sedentary. Eating fast food 4 times a week. PMH, that's past medical history. So P2G2, refresh your memories, that is pregnancy. So she's had 2 pregnancies that went to 2 births. She had a tonsillectomy when she was 7. She has a dad that takes a lot of medications, ACE inhibitors, beta blockers, and aspirin, and a mom on glipizide. So it looks like a family history of probably hypertension. When we look at her for our physical assessment, we see she's 5'2", 150 pounds. Ideal body weight listed for that height is 117. Blood pressure, you get 110/68. Pulse is 74, respiration 16. Blood sugar, so this is non-fasting. She just happened to stop at our booth. And total cholesterol of 198. So let's see what we can talk about. This is what we would love to do in class together, but we'll do that later. What would you teach as your opportunities for primary prevention? I think my focus here would be she's sedentary, she's eating way too much fast food, she's overweight, non-fasting blood sugar was fine. However, her cholesterol is borderline. So lifestyle changes she can make, reducing her weight, changing her diet, increasing exercise and activity. So this is our big deal. Then we need to know, do we need to make referrals? It's great to go do these nice health fairs and we take everybody's blood pressure, but then do they follow up on it? Her blood pressure was great today, so would we make a referral for her? It does, and we use lots of recommendations for these. The JNC 7, which I'm sorry, this is a little outdated. I believe there is now a JNC 8. So this is the organization that defines our classifications and recommendations on hypertension. I think we're up to, like I said, JNC 8 now. All right, so let's talk about blood pressure classifications. Normal blood pressure has to see, you'll notice in the middle here it says and. Normal systolic has to be less than 120 and normal diastolic less than 80. However, we'll start moving into our categories. So pre-hypertension, this means my systolic is between 120 and 139, or diastolic is between 80 and 89. So in other words, if I had a blood pressure reading of 120, which would say normal, but my diastolic was 88, that still puts me pre-hypertensive. Pre-hypertension is a great place to us to put our prevention methods here, to getting them to stay down in that pre-hypertension range and not moving up to stage 1 or 2 hypertension, which is, as you can read your numbers here, stage 1 systolic 140 to 159 or diastolic. So in other words, if I have a normal on one and the other one's out of whack, we fall in that category that's out of whack. And then of course stage 2 is hypertension, systolic 160 or greater and diastolic 100 or greater. All right, another little exercise here. Let's meet Ben. We're going to follow him for a little while. So you're doing now a behavioral health practicum. You've asked to go see Ben and do a history and physical on him. He was admitted to the unit for depression. All right, he's 32-year-old, African-American male. He's unmarried, has 2 young daughters, and works a night shift. He smokes 2 packs a day, drinks a beer every weekend with friends. He says he's active but has no formal exercise regimen. If you're doing interviews with patients, I'd want a little more information about that. What do you mean when you say you're active? Because remember, we need 30 minutes of aerobic activity every day to really meet the guidelines. He eats primarily canned and frozen meals, which we know are high in sodium. He reports that he has no past medical history when you ask him, but remember, he's admitted with depression. Family history, he has a dad that had a sudden heart attack when Ben was 2. Mom is obese, diabetic, hypertensive, has no knowledge of any sibling medical history. All right, so on our physical assessment, he sees 5'11", 171 pounds. Do a BMI, I think that's going to be fine. Blood pressure on admission was 160/98. 2 days later, 152/84. Yesterday, 148/92, and this morning, 158/94. So what do we think about his trends? I think a couple of things I noticed. On admission was a very high reading, which is not uncommon, probably a little anxious, a little more acute in his mental health disorders, whatever led him to his admission. So we would kind of expect that to be higher. And it's going down a little bit, but we do have all of them are in the, let's see if we go back and look, all of them are in the stage 1 hypertension range, because we have systolics that are above 140 on all of them. So like I said, to diagnose hypertension, 3 readings of 140/90 or greater is how we diagnose it. There's 2 main categories for hypertension, primary and secondary. We're going to focus on primary because that is where our interventions are going to be and our nursing is going to be. It accounts for 95% of all cases of high blood pressure. Remember, increased blood pressure is either an increased cardiac output or increase in systemic vascular resistance. It's usually due to an interaction. So it's not usually just your genetic predisposition. It can also be environmental, demographics, all the things combined. The reason we're not going to talk really much about secondary hypertension is this is about 5% of the cases. And the reason that you have high blood pressure is due to another thing that becomes a secondary symptom. For example, if you have sleep apnea, chronic kidney disease, these are the problems of why you're having hypertension. So our focus for treating it becomes treating the underlying cause. All right, so what are our normal blood pressure mechanisms? Because normally if we have high blood pressure, something's wrong in the midst of all this. We need to maintain a normal blood pressure for good tissue perfusion. So we use our autonomic nervous system, parasympathetic and sympathetic nervous systems increase the force of contractions, increase our heart rate, and then the parasympathetic decreases our heart rate. There are baroreceptors and chemoreceptors. These are areas where the blood pressure is detected and then adjusted. So the baroreceptors, there's one in our aortic notch, there's another in our carotid sinus, and then there's chemoreceptors. So these are what stimulate vasomotor center and increase our cardiac activity. And also our vascular endothelium, which would be the actual makeup of our vascular system that can help, because we can dilate and constrict our vessels, and that also controls our blood pressure. Of course, our endocrine system also, it has a little hand in everything in our body. All right, now our big impacts from our renal system. We use this with the antidiuretic hormones, or ADH, reabsorbing the water by kidneys, also our RAS system. All of this has a role in our blood pressure. When it detects not enough fluid in our body, that we hold on to fluid. The way that we do all those control our blood pressure. Also, temperature, your blood pressure will flux with a fever or if hypothermia, smoking, alcohol. So all of these things, nicotine, and emotional state, stress. So these are all components of our blood pressure control. Like I said, we're talking about genetics and genomics of primary hypertension. They can affect our sodium and water retention, altered renin-angiotensin. All of these things can be genetic or genomic. We still treat them the same. Let's look at what Ben's risk factors were. He had a family history, African American, male. Males, remember, males under 55 are more likely. Age, obesity, yeah, he was very overweight. smoking too much, elevated lipids, so cholesterol is too high, drinking too much, the canned foods and frozen foods that he eats are too much sodium, and he does not have a good exercise regimen. His family history there, diabetes, persistent stress, sure sounds like it. And socioeconomic status, he's poorly educated, not having access to good blood pressure, following, etc. So what diseases do we associate with primary hypertension? What are our comorbids? When you have them together, it compounds our risk. Diabetes. Hypertension is more common in diabetic patients. Insulin resistance is also a risk factor for hypertension and coronary artery disease. And then the problem with diabetics too is more target organ damage. We'll talk about that in a little bit. The disease is more severe in diabetics and hypertension are combined. When you have both of them, that target organ disease is worse. Of course, diabetics have a different blood sugar and AIC level. Again, we'll talk about that later. Elevated serum lipids. In other words, if I have elevated cholesterol and hypertension, then I have a much greater risk. All right, and interesting here, it's everyone at risk should be taking a baby aspirin a day. I think we've somewhat backed off from that recommendation only because it needs, just make sure the recommendation comes from their docs, because what if they're already on a blood thinner for some other reason? So just be careful when you make that recommendation to people. All right, the biggest problem we have with primary hypertension is it's a silent killer. Most people with high blood pressure are completely asymptomatic. So unless they are someplace where they're getting their blood pressure checked on a regular basis, maybe if their job requires it, etc., then they never know. And they walk around for years until finally they stop at a health clinic or get one of our little fairs where we're running blood pressure checks. They don't go, so it's running untreated for long periods of time. One of the many reasons that you see a lot of employers nowadays offering kind of routine biometric screening, I believe is the common word for it, where check up on your employees and find out what's going on. If, however, you are symptomatic, the most common symptoms here are subjective or objective. Subjective, dizziness, activity intolerance, palpitations, angina, all of these things can be. I think headache's probably the more common one. And then objectively, you can sometimes see some symptoms in ophthalmic exams, and we can see some alterations in their labs and even their EKG and chest x-ray. How do we test for hypertension? Okay, all of these are tests we will run in conjunction. The actual test for hypertension, don't overthink it, is a blood pressure cuff. That is how we diagnose hypertension. When we get into that, these are some other things, because we already learned about the comorbids, so we want to look out for those things. Check their cholesterol levels, check their renal function, check their urine status, so we can, again, that's part of looking at their renal system. EKG and a chest x-ray. So these are, once we've diagnosed, we're going to look at a lot of these things. All right. So we report the blood pressure trends to the doc, and let's think through what we think would be prescribed and go over this in patho. HCTZ, hydrochlorothiazide. Most patients will not be able to tell you they're on hydrochlorothiazide. They will say, I'm on the HTC, HZ, and don't get confused. HCTZ. This is a thiazide diuretic. And the greatest thing about HCTZ is it's actually very effective in most patients. However, not as effective in African Americans. The other thing that's great is it's cheap. It costs about $3 a month. So this also can be linked with an allergy to sulfa. The patients that have an allergy to sulfa should not be on hypertension, on HCTZ. Okay, so there are a ton of options for hypertension medications. ACE inhibitors, then ones we call ARBs, beta blockers, CCB there's for calcium channel blockers. And don't forget too, you will never have to decide what medication a patient should be on. That is a physician responsibility, and that's good. What you need to understand are kind of the side effects and risks and things for helping teach your patient. Diuretics are diuretics, right? So we have to watch potassium levels, sodium levels, all of the things associated with diuretics. The ACE inhibitors or prils, that's because most of those will end in, like lisinopril, probably one of the big ACE inhibitors. Sartans or ARBs, angiotensin blockers, losartan, and then the ones that end in olol are beta blockers, like metoprolol. So those are just easy ways to help you remember the categories of drugs. Remember that ACE inhibitors are prils, the ARBs are mostly sartans. This is, again, just general reminders. So what would work best for Ben is compliance, helping him adjust his lifestyle, modify his lifestyle, and then more importantly is whatever the physician prescribes for him, teaching him about compliance. Compliance is difficult to learn with hypertension because you don't feel bad. Therefore, when you take a medicine, you don't feel better. And I think feeling better is often one of the big drivers for compliance in medications. So, here we go. Like I said, first goal is lifestyle modifications. Okay. If they don't get down to a goal blood pressure, which is always less than 140/90, and then 130/80 for patients with diabetes or other chronic problems. In other words, with those patients and the comorbids, we need to keep it lower, would be a goal. And then there's choices here for initial. So if we're looking at stage 1 or stage 2, and that will guide them in different ways. And the physicians will follow kind of a algorithm like this. So if they're at stage 1, the first option is thiazide diuretics. They also may consider ACE inhibitors or combination. Stage 2 almost always takes 2 drugs. However, stage 1 can also take 2 drugs. It just becomes more option. And if they're still not at their goal, they look at adding second doses or changing doses, etc. Again, don't memorize that because it's not your job to prescribe. Just know this is what the physicians use, so you can help monitor their blood pressures and help alerting them then to say, okay, they've been on your first drug for 2 months and they're still stage 1, whatever, and you can help direct them. All right, goal blood pressure, like I said, for medications is to keep it below 140/90 or 130/90 in patients with diabetes or chronic kidney disease. The goal of medications is decreasing their volume, decreasing that systemic vascular resistance to help keep the blood pressure down. That is what the goal of these medications is. Diuretics decrease their volume, the other ones that decrease systemic vascular resistance. Most patients will require 2 or more antihypertensive medicines. It's just a given. Most of them, very rare do you find one that's just on HCTZ, which while it's very effective, it doesn't always work by alone. It may need help. All right, make sure you're teaching your patient about their medications. They should always know the name, dose, and side you when you teach them. Be specific about the name, the dose, the side effects of all the medications. Teach your patient. Help them create a schedule that's good for them. If the doc says take this once a day, sit and talk to your patient. What is a good time of day? Is it first thing in the morning? Is it before they go to bed? Is it find a good time for your patient? In other words, the more convenient you make it for them, the more likely they can be compliant. Make sure they understand, don't abruptly stop a med. Even if it's starting to make them feel weird or they think it's making them feel weird, then they need to talk to their doctor. He may want to taper off doses. We can have bad side effects by just stopping medications. Teach them about potassium supplements. If they're taking either a thiazide like HCTZ or even a loop diuretic like Lasix, they need diet supplementation of their potassium. Talk to them about what orthostatic hypotension is and ways to reduce the effects. Make sure you know how to explain orthostatics to a patient in layman's terms, that they understand. When I get up, I feel funny or I feel dizzy, so especially when they're first on hypertension medications. You're going to get hypotension or orthostatic early on. So maybe for the first couple weeks. It's important to teach patients that most of the time side effects they're having from drugs are highest in the first couple of weeks and they taper down after they've taken them. So if you can encourage them to kind of get through the initial side effects, that they'll go away. Explained here too, may cause sexual problems. This is true not just of our blood pressure medications, but a lot of them. And it's really important, especially for our male patients, that they understand there's a million different drugs they can take. So if one drug is giving them sexual side effects and problems, then there's 10 other ones we can try. So in other words, don't quit. Just make sure you talk to your physician about it, and that y'all can have a plan moving forward for trying different drugs or just waiting for the side effects to diminish. Just share, like my husband, who refused to believe he's getting older, shocker, started developing hypertension. He's fit, he's active, very active, and controlling his diet, whatever. Still had high blood pressure. I was like, honey, you're getting older and you have, his father has bad hypertension. I was like, so you can't modify those things. Finally convinced him to go to the doc. Of course, started with the HCTZ, wasn't enough, added the lisinopril. Followed a very classic, or the current recommended guidelines. But I will say, he spent the first 2 weeks with a lot of the side effects, feeling dizzy. He said feeling, kind of puny and poopy and not wanting to do anything, but they did go away, and still ended up on, like I said, a combination medications where they take 2 drugs. It's 1 pill, 2 drugs. 1 pill, a mixture of the HCTZ and lisinopril. So then he got the side effects from the lisinopril, the ACE inhibitors that create the dry cough. So that was very annoying and very hard to handle. So they switched him to an ARB. That did not work nearly as well. And then I played with the doses and we're hoping to find one that really works. The point of that being, teach your patients that there's lots of choices. There's lots of ways to manage this, and lots of options that don't, keeping them involved and keeping them on target. It's not easy. I'm certain that my husband would have been much more non-compliant had I not pushed the issue. So you can be that same advocate for your patient. I'm talking to them about trying the different medicines. This may take a while, but then once we find a regimen that works for you, it'll be easier. Talk about that with your patients because compliance is a big concern. So psychosocial aspects. Why do these patients not get treated? Why do they not take care of it? It can be for lots of different reasons, especially if they've had sexual dysfunction in the past with the medication. Like I said, compliance is a big one, not just financially being able to take it, but to take your pill every day. They don't want to be labeled as hypertensive, and I know that sounds crazy, but it's so true. My husband did not want to be labeled as hypertensive. I don't know if it's a manly thing, if it's an I'm not wanting to be getting old thing, or if it's just, I don't know, but he did not want to have that label of hypertension. So these are just things to consider to help you get your patient on track. All right, the DASH diet is one of our best recommendations. This is the diet for, I forget what the A stands for, stopping hypertension. Okay, this is actually can be used for lots of our cardiovascular disease. Because remember, our modifiable and unmodifiable risk factors are going to apply to a lot of the different cardiovascular problems. Coronary artery disease, hypertension, all of those kinds of things. So this is a great diet to learn. There is, if you'll see right on the bottom of this slide, dashdiet.org is a great website where you can learn increasing our fruits and vegetables, increasing the servings, doubling up on veggies. These are lots of little tips for getting them. It's also, I always teach patients to shop on the outside of the grocery store. I don't know if you noticed this because you just go where things are. On the outside of the grocery store, because that's where they can run refrigeration, is where all of their healthy, not just healthy, but fresh stuff, meats, produce, groceries are all on the outside of the grocery store. So I always tell my patients, shop on the outside of the store first before you go, because the inner lanes are where everything that is canned and preserved and really not natural at all. So keeping them on the outside of the store is the best. Lots of tips and things on this website too about just keeping it more user-friendly and better tasting. There are lots of good tips on the DASH diet. All right. Why do you need to worry about lifestyle if I can take a pill, right? We do. There's so many other things associated with the same risk factors. So, okay, great. We got your blood pressure under control with a pill. You didn't change your weight or your diet, then you're also more subject to things like diabetes and other complicators. So that's a good way to help keep your patient still involved in changing their lifestyle. You can see here, weight is extremely related to our blood pressure. Reducing your weight with 10 kilos, which is roughly 22 pounds. I can't do math in my head. Sorry, that was actually my dog. Lost my train of thought there. So 10 kilos. This is the bad part about recording videos or lectures at home, right? 10 kilos, weight reduction drops up to 20 points in your blood pressure. So it's just amazing. Changing diet, we can drop it 8 to 14 pounds. Sodium, you can see on here. Lots of things. And there he is again. Apparently my dog wants to learn about high blood pressure. Hold on. All right. So our teaching for them. Teach them the meaning of their blood pressure numbers and to keeping a journal. It's great to walk into a doctor's office and say, oh, my blood pressure's been up a lot lately. But if you can have a journal where they talk about what time of day they took it, what were they doing when they took it, etc. Make sure they know that even though they're going to feel asymptomatic, that the complications and the problems are real and can be deadly. Their increased risk of stroke and renal failure, etc. So they need to understand too, you have to not only take your pill, but you have to change your lifestyle. The combination of changing your lifestyle and your pill are the most effective ways to manage blood pressure. They need long-term follow-up, and therapy will not cure it, but control it. All right, some examples of nursing diagnoses associated with hypertension. Ineffective health maintenance, not managing their own health. Ineffective self-health management. Sexual dysfunction, often related to either the hypertension or their medication. It can be related to either one. Anxiety, that's a big one, especially if you had a previously healthy young man who suddenly has hypertension and they can become very anxious over that. Ineffective therapeutic regimen, disturbed body image, ineffective tissue perfusion. All right, focus our effort and resources on controlling those patients that are identified with it, identifying and controlling it in our at-risk groups. And this is huge too. Like I said, the earlier we can identify it, treat it, it lessens the effects of the actual high blood pressure. So if we get in those areas and groups that have high risk, so African Americans, obesity, blood relatives, etc., and go ahead and get screenings done, and then of course always demands individualizing medications. All right, hypertension in older persons, more than 2/3 of people over 65 have hypertension. And yet they have the lowest rate of blood pressure control. Treatments should be the same whether they're older or not. Initial drug doses can be lower to help avoid symptoms. Again, not a nursing concern, but these are your guidelines for it. So what do you mean by resistant hypertension? Resistant hypertension is only a couple things. Improper. So we go in and say, I've been taking my medication just like you prescribed, and my blood pressure is still up. Make sure the blood pressure is being taken correctly, especially our patients that are using the automated blood pressure readers like CVS or at home or whatever. Those are a one-size-fits-all, which as we know is not the right way to take a blood pressure. So the patient who says, why isn't my blood pressure going down? Well, let's make sure it's a good reading anyway. Or the patient says, I take my blood pressure every day, but then when you start talking to them more, you find out because they're also still eating way too much sodium. You have to can't overact that with just a pill. Or it is a case of, yeah, you're doing exactly right. We're just not giving you the appropriate therapy. So it's inadequate or inadequate doses, or drug interactions too. So I take my pill every day. It's great, but we don't even know if that pill's working or not because they're taking over-the-counter drugs, illicit drugs, NSAIDs, herbals, all those things that are interacting. So that's actually what's causing it to be still up. Excessive alcohol, or we haven't actually identified the cause. So it turns out maybe it's a secondary hypertension and we haven't found the cause yet. So lots of things to look at why a patient's blood pressure is still up. All right, let's check back in on Ben. This is 4 years later. He lost his job, unable to receive unemployment benefits at this time, and his mom died. So as a coping mechanism, he admits to drinking beer every afternoon. So we've increased the risk of the alcohol. So let's talk about poor Ben. Lost his job. If he had benefits, he could have lost those. He can't get unemployment benefits, so a financial problem, which we know can lead to trouble getting his medications, trouble getting good, healthy foods. And his mom died. That's an increased stressor. And as I said, he's trying to cope by drinking, which is never a good idea. Now he actually comes into the ED and he has complaints of feeling tired, headache, indigestion. And obviously y'all can't answer me here, so that's okay. So when we look at Ben now, he is 5'11" still, 213 pounds. That's a 42-pound weight gain from his last admission. Blood pressure is now 210 over 104. Pulse rate is 110. Apical regular heart sound with positive S4. Neurologic exam is unremarkable. So it's great. Hypertensive urgency or hypertensive emergency. So is this an urgent situation or an emergent situation? 210 over 104, obviously too high. So let's talk about hypertensive crises. Hypertensive crisis is kind of the general term here. So then we have urgency or emergency. Urgency actually tends to develop over days to weeks. Emergency develops more quickly, hours to days. Blood pressure severely elevated in both cases. However, in urgency, there's no evidence of target organ damage. In emergency, there is, and we'll talk more about what target organ damage is here in a couple of slides. And it is often higher in emergent situations than urgency, so greater than 220 over 140. So the way we differentiate between the two is how long did it take to develop? We may not know because we don't know when he had a blood pressure checked. We can only determine that more in hospital. But more importantly here is target organ damage. Is there evidence of target organ damage? If there is, then it is an emergency. If not, then it's urgency. Okay? Target organ damage, like I said, we'll talk about that in a couple more slides, but when we can actually see the damage of the target organ, so the end organ, where the hypertension has damaged organs, and we know the risk of which organs are damaged. All right, so we do have to differentiate which one he has. So we want more information. We have to figure out, are there target organs involved here? EKG, that's going to give us information about the heart. Lots of labs we're going to do. We can look at renal function, cardiac function, lots of our target organs on labs. Ophthalmic exam, we want to look at his eyes, his retinas, or not us, docs. And the chest x-ray, we're looking at his lungs and his heart size as well. So, how do we end up in this situation of this hypertensive crisis? It's typically an exacerbation of chronic hypertension, most often not taking their medications. That's all there is. renovascular hypertension. All right, and then there's just some other ones that are, some of these are secondary or other causes. Preeclampsia, we know this is associated with pregnancy. Pheochromocytoma, also more likely. Drugs, especially cocaine, amphetamines, they increase blood pressure and can do it dangerously high. MAO inhibitors, if you take it with foods that have tyramine, can cause a problem. Or rebound hypertension, so abrupt withdrawal. Head injuries, aortic dissections, all these other things can cause this hypertensive crisis. These are not all of them. Some of them are, this is a list of some of them, sorry. All right, so what is target organ damage? When we look at what is the danger in high blood pressure, what problems do we have created to it? That's what we're looking at. Target organs, so the organs that are damaged from this. In our heart, we have left ventricular hypertrophy, angina, or an MI, prior coronary revascularization, heart failure. Brain, so we can have stroke or ischemic attacks, chronic kidney disease, peripheral artery disease. If you want to make more sense of this, you go back to slide 14 and do it in the slideshow mode so you can watch the link. There's a little comment on there that says, what is blood pressure? If you click on that, it takes you to a little video. It seems weird, but there is, and it's a good example of how this target organ damage develops. All right, as you can see, if we can lower our blood pressure, we reduce this risk. Reduces strokes risk by up to 40% reduced. Risk of a heart attack, 25%, and risk of developing heart failure, 50%. 50%, it's huge. And all we need to do is get our patients to be compliant with their medications, diet, and lifestyle. I know, sounds simple, that's all I say. All we have to do is, but it's true, get them reduced these things. Again, probably not a good thing to do when I have nobody to answer the question. We'll use these in recitation. And there are just 3 slides here on hyperlipidemia, which is not just cholesterol. There's lots of lipids. So any elevation of your lipids is considered hyperlipidemia. LDL, HDL, put them together, you get total cholesterol. These are being reevaluated every year. They put out some new guidelines last year, which are becoming very patient specific. But still, the one thing that didn't change, is overall total cholesterol should be less than 200. Between 200 and 239, they're defining as borderline high, and anything above that is high. We can look at LDL, which we actually want low. Low. Less than 100 is optimal. Between 129 is pretty good. 130 to 159, you're already into the borderline high range. And then LDL, we want that less than 40 is ideal. Is too low. I'm sorry, is too low. 60 is high. So HDL is an interesting. We want that one to be a little bit higher than our LDL. LDL's low, HDL's high, H and L. Keeping that total cholesterol. And there's a lot research going on in this field of what matters. Is HDL more important? Is LDL more important? Now there's ratios. They want to know what is the ratio of your LDL, the ratio of your HDL. So there's lots and lots of research going on about these. Like I said, and hence the new guidelines they put out, which were putting more and more patients on cholesterol-lowering drugs. But again, the biggest thing we can do to affect cholesterol levels is diet and exercise. Those are the 2 biggest things we can do. Because you got to remember too that none of these are without risk factors. The medications, all of these things have side effects. They have risk factors. So then you play a game between what is better, your cholesterol, medication, and you play this balancing act. Like I said, there are new guidelines that came out in November of 2013. You can take a look at these, and you'll notice now they put out a risk calculator. This is physician driven, by the way, where the patient, you put in the patient-specific information. You're putting in age, whether or not they've had previous cardiac event, lots of information to decide whether or not they should be on a cholesterol medication. And there's still some debate on this one because new guidelines take time. The one that never changes and won't change are lifestyle modifications. Heart healthy diet, regular exercise, quit smoking, and a healthy weight. These are things we have to emphasize. These are not only going to help with their lipid levels, it's going to also be great for hypertension. It's good for diabetes. It's good for everything. These are just can't fail recommendations.